Today's date is April 23rd, 2024, and the topic for the lecture is entitled Predicting and Planning for the End of Life Care. My name is Pat Redshaw, and I am a member of the Board of Directors at Gateway. Gateway is a not-for-profit organization based in Huron County with a mission to improve the health and well-being of rural residents through research, education, and communication. To our knowledge, we are the only rural health research center in Canada governed by a committee-based volunteers not attached to a research arm of a larger academic institution. This lecture is part of a knowledge translation project to promote and mobilize the understanding of health in rural communities. Before we begin, I would like to start by acknowledging the land. The Gateway office resides on the traditional territories of the Anishinaabe and Haudenosaunee and Neutral peoples. Under the dish of one spoon wampum, these groups agree to care for the land and its resources by the Great Lakes in peace. We would like to acknowledge the history of the traditional territory of the land known as rural Southern Ontario and honor the long-standing relationship of the Indigenous peoples across the region. Gateway Center of Excellence in Rural Health recognizes the inequities connected to colonization, which can impact health outcomes, and we are committed to working towards creating an just, inclusive, and vibrant community for all. Death, dying, and the end-of-life care are difficult yet important topics to discuss. Co-presenters, Erin Donald, PhD, Director of Clinical Services at the Huron Hospice, and Meagan Nolan, MD, Medical Director at the Huron Hospice, will develop an understanding of these topics. Dr. Donald is a registered nurse with an extensive career in palliative care as a clinician, educator, and researcher with a focus in equity and access to palliative care. Dr. Nolan is a family physician in Seaforth who provides consulting medical and policy expertise at Huron Hospice. Supporting this discourse are three panelists. Laura Hawkins, RN, who manages the Huron-Perth Complex and Palliative Care Outreach teams. Tracy Snell, RN, and Executive Director of Jessica's House. And Lorna Coombs, RN, a Nurse Educator for Palliative Pain and Symptom Management Consultation Program. To thank those that are ongoing attendees, we offer certificates at the end of each seminar to those with perfect attendance to recognize your commitment to and involvement with the educational series. Today's lecture, May and June's lecture are all part of the spring semester of Gateway's virtual lecture series. Earn your own certificate by attending those upcoming events. Throughout the lecture, we encourage participants to ask questions in the chat box. We will answer them and they will all be addressed. A brief disclaimer, the views expressed in this lecture may not necessarily reflect Gateway Center of Excellence in Rural Health's views and opinions, but we believe in providing a platform for a range of perspectives and thoughtful discussion. And at that, I'd like to turn it over to Erin and Meagan.
Thank you so much for having us. My name is Dr. Erin Donald. Myself and my colleague, Dr. Meagan Nolan, will be presenting today. So I'll just launch into it. And Dr. Nolan, if you want to take it away.
All right. Hi, I'm Dr. Nolan. We thought it would be beneficial to start with some definitions and concepts of what palliative care is, because there are some people that have misconceptions about it. So sometimes when we talk about our work to other people, they think it means giving up or throwing in the towel. But that can be a really hard thing for patients and loved ones to hear when we start talking about palliative care with them. But actually, the guiding principles of palliative care is living well until you die. Palliative care is about comfort and excellent management of symptoms like pain, shortness of breath, fatigue, and others that can afflict people at their end of life and in their illness trajectories. So a palliative approach, what is it? It's about maximizing the quality of life and managing symptoms anywhere in the healthcare system. And it is care that can be delivered by any healthcare provider. It is an approach to the care that someone can already be receiving, be they in hospital, long-term care, or recovering at home. And it brings the principles of palliative care to any type of treatment, and ideally should start early in the illness trajectory. What is palliative care? So palliative care is a whole person care that treats someone with a serious illness and their chosen family, friends, and close support systems. It is also focused on improving their quality of life and managing symptoms, as well as providing psychosocial, spiritual, or decision-making support as an illness changes someone's life. Palliative care also includes bereavement support for loved ones before and after someone has died. Palliative care can be provided by healthcare providers in any setting or in partnership with specialist teams. While palliative care often plays a larger role in someone's treatments as their illness advances, it can be in place while someone is still receiving active treatment that is intended to cure. So some people believe you can only have palliative care at your very last little bit of life, but that's not true. We would prefer it to begin when somebody has been given a life-limiting illness, because then we can help in many ways. And what is end-of-life care? End-of-life care describes the care that is provided to someone in their final days and weeks. This care continues to be whole person centered and guided by an individual's wishes, even when they are no longer able to speak for themselves. Hospice care. How is this different from hospice care? Well, hospice care in Huron County provides palliative care to individuals and their loved ones with a serious illness who are no longer receiving treatment intended to cure, either because it's not possible to cure their illness or because the burden of treatment is outweighing the benefits for them. In Huron County, hospice is not restricted to the last 2 weeks of life, but can be an option for individuals and their loved ones to spend their final months and weeks well supported by healthcare providers with expertise in palliative care. We'll talk about that a bit more later, but first let's talk about what we mean by a serious illness. So a serious illness can be any illness that is life-threatening. When we talk about serious illnesses, we were referring to cancers, yes, but we're also referring to illnesses such as congestive heart failure, chronic obstructive pulmonary disease or COPD, renal failure, which is kidney failure, liver failure or dementia, or any other illness that can lead to a decline over time and potentially shorten someone's life. We have made great advances in caring for people with serious illnesses towards the end of their lives, but too often a person's decline and death still comes as a surprise to them and their loved ones. Despite this feeling of surprise, there are almost always signs in serious illnesses that can act as sign points to healthcare providers, family members, and patients themselves. These can help cue important conversations about healthcare options, goals of care, and future plans. While everybody's individual illness journey is different, we know from studying large numbers of people that different illnesses groups tend to follow different patterns. So if you look at this graph that is presented, so the first line there in purple is sudden death. So that could be from a motor vehicle accident, a heart attack, a stroke, or a blood clot in the lung. So that is a pretty quick, swift death in time. The black line is cancer deaths. So you have a kind of slow decline for quite some time. And then as the illness progresses, a slightly steeper decline until death. And then at the end, a fairly swift decline. The red line is organ failure. So that could be chronic kidney disease. That could be congestive heart failure, chronic obstructive pulmonary disease. So that if you notice, they are not functioning at their high functioning level. They're kind of in their middle function in their lives, and they slowly deteriorate, and then they have a sudden decrease. So this could represent a acute exacerbation or a hospitalization or an ER visit, and then they recover, but not quite to the level that they were at before. And then they slowly decline again, and then another drop and another slight recovery, but not quite to the level they were at before. And this continues over time until they have a more steeper decline towards the end. And then at last, the blue line is physical and cognitive frailties, such as just getting old age, and cognitive frailty, dementia, Alzheimer's. So they have they're functioning at a very low level, usually needing some supports, and then they just slowly decline over time until their inevitable death. One thing to point out, though, is some cancers, instead of following the black line, with all our advances in cancer care and symptom management and treatments, can sometimes follow the red line more closely. So cancer doesn't always follow the black line. Sometimes it follows the red line. Okay. So what are some signs of decline? So each serious illness has its own course, as we said. But signs of decline in one illness, such as congestive heart failure, aren't the same as signs you might see in cancer or lung disease. But us physicians and healthcare providers, we don't always have a crystal ball, but there are some things we do look for to see how that can point towards a significant decline in the final months of someone's life. So some of these signs might include weight loss, limited functioning. So they may be not getting around as well as they used to. They may find self-care tasks to be more challenging, may need some more supports in the community, some PSWs, some nursing care. And they may be spending more time in a chair, on the couch, or in bed, not getting up as much as they used to. Decreased appetite. Sometimes this just happens with age, but sometimes in illness, it definitely is a big issue. Another one that we see quite often is increased emergency room visits or hospitalized admissions, especially visits that are happening more often towards their end of their life. Shortness of breath with activity or rest is another one. And this is a very powerful diagnostic sign in someone with heart disease, lung disease, or lung cancer. And sometimes there are other specific illness markers, such as swelling in the legs or abdomen, which we might see in somebody with heart failure or liver failure. So understanding the trajectory of a serious illness and knowing some of the signs of decline helps trigger us to think about when it's time to start to revisit some more important conversations. Okay, so many Canadians may not even be aware that the illness they have is one that is anticipated to worsen or shorten their lives. So serious illnesses can include illnesses with the possibility of a cure, but it doesn't always work out for the patient. That's why you'll sometimes hear the phrase, hope for the best, plan for the rest. So many Canadians also hope and expect that the right person, a doctor or a nurse practitioner maybe, will tell us clearly and plainly at the right time when we're ready to hear it that an illness is life-threatening, and we should gather our questions and start making plans. But for one reason or another, this doesn't always happen. There may not be time for the discussion. We may not always hear what our care provider believes they have clearly conveyed. This sometimes happens where I've told somebody, about their life-limiting illness and they didn't hear what I said or weren't able to hear what I said. They weren't ready for it. Some of us have very limited access to healthcare providers and maybe receiving a diagnosis for the first time in a very busy emergency room or a hospital ward, may not have access to a family health team or nurse practitioner. That's why it's important to be ready as individuals to start these conversations or revisit these conversations ourselves, empower ourselves to ask the important questions. So Health Canada recommends that we ask our health provider these 3 questions when we're given a diagnosis. Is this illness curable? Will it get worse over time? And will it shorten my life? And then some other questions that we recommend would be, can you explain the different stages of my illness? Am I currently in the beginning, middle, or end of my illness? And another one to ask is, and what milestones and decision points are ahead in my illness, and how can we plan for them?
All right,
Erin, on
Dr.
to you.
Nolan. Yep. So of all the things that we plan for so carefully in our lives, so think about childbirth, think about weddings, think about careers or retirement. There are so many people who don't necessarily plan for death or leave it until the last minute when so many other things are changing and now feel out of control. Planning for declining health and end of life is about person-centered decision-making. Person-centered decision-making is making sure that you have a voice in your healthcare decisions. When we're first diagnosed with a serious illness, if curative treatment is available, everyone might be on the same page without a lot of discussion being needed. But all treatments have pros and cons, costs and benefits, and we deserve to know what these are and really be able to make an informed choice about what we want and what we don't want. Advanced care planning helps us think about the future and what we want for our own care. It's an exploration of our values, our beliefs, our goals, and our preferences about our lives, our illness, and our death. Advanced care planning ideally starts when we're healthy and gets more specific with a new diagnosis or a change in health status. Advanced care planning encourages us to think about what makes our lives meaningful, what are our hopes and worries about life and death as illness progresses, and what's most important for the people around us to know. Advanced care planning can just be an unstructured conversation, or it can be supported by a workbook or guide, but it's not something that has to be written down. It's important to know as well that an advanced care plan is not the same as a DNR or a do not resuscitate order, which is a process that is put in place when a person decides they no longer want to have CPR. It's important to understand the costs and the benefits of CPR as someone advances in an illness trajectory, and that's part of an ongoing goals of care conversation, but it's not the same. Knowing where you're at in the illness trajectory and in your own illness journey is an important part of person-centered decision-making. Without knowing about your own situation, it can be hard to make specific informed decisions about your care. And that's the purpose of a goals of care conversation. So a goals of care conversation is when you, your chosen decision maker, and your healthcare provider check in and talk about your illness and how your values and your beliefs and your goals and your preferences are being respected in your care, or how your priorities might have changed in light of new information about your illness and treatment options. For healthcare providers, the Serious Illness Conversation Framework is a great guide for goals of care conversations with person-tested language, and it's a very natural flow to the conversation. So that's a resource as well for those of us who are coming into these conversations from the other side. When you're considering your values, beliefs, goals, and preferences, it's also good to think about who is it that needs to know this information about you. Certainly your healthcare providers do, but you also want to think about who would want to speak for you if you were not able to speak for yourself. Under Ontario law, there are default substitute decision makers identified for you in a situation where you haven't appointed someone else. So if you're married or in a common law relationship, your spouse is your default substitute decision maker. If you're widowed and have children, your children will jointly share the responsibility of being your substitute decision maker if you're unable to speak for yourself. But you have the ability to name a power of attorney for personal care if you want to designate a specific person. You don't have to go to a lawyer to do that. All you need are 2 witnesses, and you can download a form from the provincial website. It's good to keep this in mind because the person who's closest to you may or may not be the best person to speak for you if you're unable to speak for yourself. The best power of attorney is one who can most closely align with your wishes. If you know that a loved one is going to have a hard time following your wishes, or you want to alleviate them of that responsibility of decision making, it's okay to have that conversation to say, I really want you to be able to be my daughter or to be my husband because I care about you so much. Whether you decide to keep your substitute decision maker or name a power of attorney, it is still so important to have a conversation and to revisit that conversation as your goals of care change. Ideally, the people who are closest to you and your power of attorney should all have been able to hear from you what's important to you and what you want before anything that threatens your ability to communicate that. Writing it down in an advanced care planning document like the one created by Speak Up Ontario can be helpful, but it's the conversation that is really going to stay with someone. And of course, this is an ongoing conversation that can be revisited at any point in the illness trajectory, but especially when someone has had a major change, such as a change in functioning, or you're starting to see some of those indicators of decline that Dr. Nolan talked about earlier. So talking about options for care, moving into kind of making some of those plans. An activity that we sometimes see in palliative education, and Lorna's gonna kind of be smiling to this because she does that palliative education. She does these kinds of activities with us, or advanced care planning workshops, is when we're asked to picture our own deaths, or to maybe draw our own deaths, or write about them, or otherwise describe them, reflect on them in some way. Sometimes these aren't necessarily realistic. For example, I drew myself on a dock by my childhood cottage, but I know it would be unreasonably hard for my family or a funeral home to get down the rocky steps that led down to it. But it helped me to think about the things that were important to me, where I might want to be buried or have my ashes spread, that I would want to be able to feel the wind in my hair. Exercises like this help us think about what's important to us, which is good because our ideal is not always possible. Most Canadians want to die at home, and for many, this is possible, but sometimes it's not. A person can live much longer than expected, which can cause challenges for family members who have limited time off work to provide care, or care needs might exceed what's available in the community. Home care teams do amazing work, but there are limited resources, and a person with a serious illness might unexpectedly need more care than these services are funded to provide. Even private pay care isn't always available, or isn't always available to bring in as quickly as you need it. Family caregivers find caring for a loved one to be rewarding and deeply meaningful, and it can also be exhausting and more intense than either the person or their loved one expected. That's why it's important to know your options and to have a backup plan. If things break down at home, the default can be that you end up in the emergency room, which may or may not be where you want to end up. This might not align with your wishes. We do have another option in Huron County, which is hospice. So hospice is an option for end-of-life care in Huron County, and contrary to popular belief, is not limited to the final 2 weeks of life or when someone is actively dying. When someone stabilizes or we're able to get their symptoms under control, sometimes residents will even go home. When a person's goals of care are to maximize their quality of life and they are no longer pursuing life-sustaining treatments, or life-sustaining treatments aren't possible, hospice is a wonderful alternative for care. Some myths that we hear about hospice are that it's dark, it's depressing, it's sad, that it means giving up. In fact, hospice is a place to live well until death occurs. Often there is much more living and healing and conversation, sometimes even lifelong healing that takes place in hospice. There's music, there's home-cooked meals for those who would like to eat, there are pets, there are new and old connections, there are tears, but there is also laughter and joy. We also hear that hospice is expensive. It's not. There is no cost to staying at hospice, no matter how long you're here for. And there are supports available for anyone who isn't able to cover the cost of transportation to get here. We sometimes hear that MAID isn't allowed at hospice. This is no longer the case, though different hospices are each approaching MAID differently. There are 3 hospices in Huron County. There's Huron Hospice in Clinton. There's Jessica's House in Exeter, and we have Tracy here from Jessica's House today. There's also Rotary Stratford and Perth. We're from Huron Hospice, so that's what we're going to talk about kind of here. Though this information is going to be similar between each of our homes. And on this slide here, we have some pictures from from Huron-Hospice, just to kind of give an idea of what a stay might look like. So we have a big family meal going on there. That's just sort of a picture of the building. It's an example of one of our rooms with someone coming in, doing some music, and a living room where family members might spend some time together. So I've put the numbers here for Huron-Hospice and Jessica's House. You can call and speak with Tracy or I or any of our nurses if you have questions about hospice or about a referral. All referrals for hospice in Huron County come through home and community care. So if you're connected to a home care nurse or a care coordinator, you can speak with them, or you can call this 1-800 number and ask to speak with intake if you'd like to be assessed for a referral. Home and community care is also available to you if you have a serious illness. You're finding that things are starting to get harder at home. You're starting to see some of these declines. You can self-refer at that point as well. You do not need to wait for a healthcare provider to say, it's time to sign you up for home care. You do not need their permission to self-refer. If you feel that you have needs in the home that aren't being met, you can reach out to home and community care and get an assessment set up. And Laura can talk a little bit more about that if anybody has questions, as she is here with us today too. The Waiting Room Revolution is a fantastic resource for patients, for families, for healthcare providers even. It's a movement that has been started by Dr. Sammy Winemaker and Dr. San Tsao. They have a podcast at waitingroomrevolution.com. Dr. Sammy is also on TikTok. She does some great sessions. They are a palliative care physician and a health services researcher. They have also written a book together called Hope for the Best, Plan for the Rest. This book is available through the Huron County Library System. We hope to be receiving more copies of this book, so check back with us at the hospice if you're seeing that there's a long wait at the library and you want to check it out. I've also provided a link to the National Advanced Care Planning, to some National Advanced Care Planning resources if you're looking for more information about that. Another resource is Speak Up Ontario. These websites can provide you both with some guidance for starting conversations, like some tips and tricks, and tools to document your wishes if you want to take that step as well. There's also a Health Canada fact sheet about what to do when facing a serious illness that can be a good starting point, particularly that can be a good starting point around starting some of those conversations with your healthcare providers if you feel like you want more information. The link was not friendly to put up on a PowerPoint slide, but you can do a web search for it, or you can give the hospice a call if you'd like, and we'll send you the link. And that is all I have for the presentation. So I'm not sure if you would like me to get out of the slides or leave this up so folks can see the resources and have a chance to write them down. What do you think, Pat?
I think you could leave the slide up for just a couple of minutes and
Okay.
so that they can write down the resources, because there are a lot of good resources there.
Okay, great.
So I'm going to get you to introduce your panel.
Yeah, so I guess I will. Well, I guess I'll invite my panelists to just do a short introduction for themselves. So why don't we go ahead and start with you, Lorna?
Okay, thanks so much. That was a great presentation. So my name is Lorna Coombs. I'm a registered nurse, and I'm a nurse educator with the Palliative Pain and Symptom Management Consultation Program, which is a long name, but it basically means that I do healthcare education across Huron-Perth region with any healthcare provider around hospice palliative care. So Erin talked about, I do a course called Fundamentals of Hospice Palliative Care, where we do draw our own death to kind of explore our own feelings about death and dying before we go and work with others that are also facing that. And I also teach the Canadian Serious Illness Conversation program, which Erin also mentioned. So yeah, that's me.
Great. And how about you, Laura?
I'm Laura Hawkins. I am a patient service manager at Home and Community Care, and I take care of the care coordinators that are involved with complex palliative patients, as well as the palliative care outreach team in Huron-Perth.
Which leaves Tracy.
Hi, I'm Tracy Snell. I'm the Executive Director for Jessica's House. So as Erin said, a hospice in Exeter. I'm also a registered nurse, so I would be working with anyone that is having any questions about being admitted to hospice or also being able to provide grief and bereavement support for them.
All right, so I'm going to go ahead and stop the share, and then we'll start taking some questions.
Excellent. So the chat is open for anyone who would like to ask a question. I do have one in here right now. What services are available to me through home care, and how do I access them? So I think that might go to Laura.
Yeah, that would be
There you go.
perfect. So if you're looking for palliative supports, that number that Erin had up there, so 1-800-811-5146, you would call yourself if you wished to ask if, get a file started, and you'll be asked a whole bunch of questions. Or your doctor would send in a referral, or if you ended up in hospital. So there's multiple different ways, but you can call yourself. For palliative patients, we have nurses. They would go to your home in a case where you're not able to get up and out doing things. We do have nursing clinics that a lot of our patients go to. That way, if you're still able to get out and live your life, we don't want to tie you down at home by waiting for a nurse to come and visit. So going to a clinic at a time that you've booked, it gives you a lot more freedom. PSWs, when you require care at home, physiotherapy, occupational therapy, we have equipment for palliative patients. So there are lots of resources, and the care coordinators also can help you with finding other resources, whether it's a visiting hospice volunteer, someone just to talk to you, or if someone else needs say social work support, we can set that type of thing up too, whether it's something that we fund or whether we help you get connected to the other resources.
Excellent. Excellent. Thank you very much. I'm not seeing a lot of questions coming up, so I'm going to ask another one. I want to have a discussion with my family about what's important to me at the end of life, or not necessarily the end of life, but when I'm getting sicker. But I don't know how to approach them. I'm afraid that having this conversation is going to upset them, and I don't want to cause any distress. But I want to have the discussion. Any suggestions about how I go about that, or is there anybody out there that can help me cross that bridge?
I can take this one, if that's okay.
Okay.
Yeah, so I think this is a great question, because I think it is a very daunting task to kind of bring these conversations up. It's not something that we usually talk about around the dinner table. But as Erin and Dr. Nolan talked about, it's just so important that your family or your substitute decision maker understands what would be important to you. So Erin already talked about Advanced Care Planning Ontario.ca, and they have great resources to actually give you a script to bring those conversations up, but making sure you're, making it, you have privacy, you're comfortable where you're talking, and you have some time to spend are all important things to consider. And then in terms of opening the conversation, right, you can, we really hope conversations like this happen when people are not in crisis. So we can start with, things are okay right now with my health. I'm feeling pretty well, but, I just know it's really important for you to know if something was to change, and I couldn't speak for myself, that you would know what I would want. And you're really important to me, so I want to share that with you. And then I would actually go through one of the workbooks, because it offers you all the questions, because starting a conversation about your wishes and values, like that's a huge conversation, and having something to kind of direct that is really helpful. And I just a point about, you know, you don't want to cause distress, right? You don't want to bring these conversations up and potentially make your spouse or children upset. But really, research has shown that when we have these conversations early and often before crises occur, that people cope so much better with the emotional distress in that situation. So it's really worth it to have the conversations out front. It might be uncomfortable at the time, but over the long term, you know, their experiences of grief, they're, you know, managing those situations when they come up, they're so much better prepared when they've had those conversations. So that's the motivation behind it.
That's excellent. I was in my previous career prior to retirement, I was a financial planner, and we used to have a booklet that I would take out and go through questionnaires. It sounds like it's very similar. Are those booklets available to be able to take out and work through on your own, or?
Yeah, absolutely. So Speak Up Ontario was always what the organization was called. And if you type that into Google, it'll still come up. But the website is actually advancedcareplanningOntario.ca. They have both booklets you can print out and online resources. You can actually type it up online and save it. Depending what generation you're from, you'll choose a different mode of saving that information. There's actually like card games you can do. They've really tried to make it as you know, low barrier to entry. And some of the questions, you don't have to talk about death and dying, actually. You can just talk about, like, what does dignity mean to you? How important is your independence? Like more general questions as well, even to get the conversation started. So there's lots of resources out there. Yeah.
Well, excellent. Thank you.
I would say, as well, as a family physician, I facilitated these discussions with family members as well. When people have life-limiting illness, I offer them to bring their family member in with me. I book a bit more time, and I kind of help them go through it with their family member in a supportive way. And we also have those booklets at our family medicine offices as well, and we hand them out when people want them.
That leads you into one of my next questions. If I wanted to have the discussion with my doctor, how do I open that up? It's one thing having.
Bring it up. We're ready for it.
Oh, okay. So just bring it up and talk and mention it to them, because it's not a conversation.
When people want to bring it up, because at least when I try to bring it up as much as possible, but I know physicians are busy. We don't always have the time. But I really kind of try to hammer it into my patients that we need to have these conversations early and regularly, so that your family knows. It takes a lot of weight off. But family physicians are well able to help a patient with this, and they should have no fears in bringing it up with their family physician. And we can also sign forms, like some people will. We can also sign Ontario government forms if patients want to be a do not resuscitate, that we can sign them their government forms. We scan them into the chart, and patients can put them on their on the refrigerator and have them handy if that's their wishes as well too.
Excellent. I do have some questions here. I have heard a death cafe is coming to Huron County. What is that? Is the question that I'm being asked.
Do you want me to answer that, Tracy? All right, so death cafes are already here in Huron County. We've been having death cafes for quite some time now. I couldn't tell you exactly how long, but the idea behind a death cafe is that it is an opportunity for members of the community to just come and have kind of some lighthearted, open conversation around issues about death and dying and life, and what makes life meaningful, what is a meaningful death, with the idea that we're moving away from the taboo, from the notion that death is something that we can't speak about, or is going to be really troubling to speak about, because that taboo is what leads to not having conversations, and then maybe your wishes aren't known, or we don't reach out to our friends who are grieving because we're worried about bringing up feelings of loss, when in fact all of us will die, all of us will experience feelings of loss through our lives. So the intention is just to have a no pressure environment where these topics are explicitly on the table.
Excellent. Next question. What role do you believe hospitals in Huron should have with regards to palliative care? Are there areas that you feel hospitals should focus on or improve on?
I would
Alright.
say as a oh, sorry.
Sorry, go ahead.
So I would say from a physician perspective, we do a lot of palliative care in the hospitals in Huron County. I also work in the hospital. I work in Emerge. So we do a lot of palliative care in Emerge and in the hospitals. The nurses are very well versed in palliative care. The physicians, for the most part, are fairly well versed as well. We try to center the patient and respect their wishes. Some patients want to die in hospital. Some are offered to go home with palliative care support. Some are offered hospice. And some people deteriorate too quickly that unfortunately they do pass away in hospital if it was not their wishes, because it's hard to move them. But I mean, patients have a right to die wherever they want to. And I think hospitals do play a role. We do play quite a big role in it. But I think if we start having these conversations earlier with patients, then patients may be able to pick the place that they would like to pass away earlier, so that we can get them the supports in place and they don't have to come into hospital. We could get them in the hospice or more supports at home if these conversations are happening earlier.
Excellent. Next question. How to find an executor for your will if you are single with no children? Will a law firm execute a will?
To the best of my understanding, this is a conversation to have with your lawyer in terms of what options might be out there. Laura, would you say that's the case? Yeah.
Yeah, and I'll speak as a financial planner. Have the discussion with your lawyer. And if you are looking for executors, some lawyers are executors. Some financial institutions have executor services. There are lots of different areas you can look at, but the starting point would have a conversation with your lawyer. Yeah. Next, you mentioned that it was a myth that you can't get into hospice until approximately 2 weeks prior to the expected death. What are the guidelines, and is it still related to a person's PPS?
Shall this be my turn to answer?
Yeah, go for it.
It very much is a myth. Because as all the panelists have said, we hope that people talk about this earlier and are able to actually be using the resources that hospice have. So being able to have a referral to hospice before this, and like I said, utilizing the grief and bereavement supports, the actual usage of using a hospice as a place to die is dependent on the hospice. And I think it's having those conversations, but I think the biggest thing is as we're talking about this, is having those conversations. And if hospice is a place where you would like to have your last weeks to months, then it's having those conversations and having those referrals in so that we can work with you as you're taking the path for the most appropriate time for you to come in, because some people do need to come in a little bit earlier because of the psychosocial supports that are needed. And some people want to be able to stay at home for as long as they're able to, and then they utilize hospice care for the very end few days of their life. So it's very dependent.
Excellent. Thank you, Tracy. There's a question here. What is the current wait time for hospice placement in Bruce County? Do we know that?
So I can likely speak up for that. So it's not necessarily a wait time for hospice placement. So you can, have a referral, even in Huron, in any of the hospices actually. You can have a referral into hospice, and it's based on what the patient's needs are versus an actual length of time. So it's nothing to do with how soon you got your referral in. It's not at all like long-term care. It's based on what your health is and your social situation, as well as what beds are empty at the hospice at the time, and as other people that are waiting for hospice. So there's many, it's very variable. It's not just a length of time.
Okay. Just wanted to affirm what Lorna spoke of. The discussion guide is amazing. That was a comment that was written in the questions, so thank you. Next question, does Huron County have access to death doulas, and how would they access this service?
I can speak to that one too. So a death doula, they're not a registered entity. So they would be private. So it would be more of a Google search that you would do. There are death doulas in Huron County and in Perth, but it would be something that you would look up on your own. They practice differently based on what their schooling was. And so you'd have to find the one that is right for you. It's not something that is publicly funded.
Okay. Another question, if someone lives in Huron County, are they limited to which hospice that they go to depending on where they live? Or is it if someone was in the northern part of Huron, could they come down to Jessica's house? Or how is the decision made where you end up going into hospice?
I think this is another Laura question.
Yeah, so it's patient preference, where you feel you want to be for your end of life. If you choose hospice, you know, it could even be in a different province, if you made that decision early enough. So it's not limited to where you live at all. It's based on what your preference is. And then once, you know, if and when there's a bed available for you, that you're able to transfer there without too much risk.
Excellent, thank you.
And I just want to add in on the note of transferring without too much risk. And this is one of the reasons that we wanted to do this presentation, that we wanted to talk about, you know, the myth that hospice is just for people who are at the very end of their lives, or talk about some of the myths around hospice, because so often we hear from people who come into hospice, wow, I wish I had known sooner. I wish we had come sooner. I wish that we had had more time here. And sometimes the risk when we're waiting until the very end of their lives, or we're like, you know, trying to hold on to the very end, is that the transfer isn't safe. And so even if the hope is that you want to spend your final days in hospice, or hospice is your preferred location of death, that by the time that happens, we're not able to get you here. And that's why having those pre-registrations, you can pre-register for hospice, you know, having those early conversations about end of life. You can come and tour hospice. You can come and tour any of the hospices at any point. If you're considering, if you're just shopping around, except it doesn't cost anything to come here, you can just look at it. Yeah, if that's something that you're considering. Yeah. All right.
So I'm just going to throw it out. If there are any more questions, please enter them in the question and answer section, and we will deal with them. We've got 10 minutes. Or if you ladies have anything else that you've thought of that you might want to let us know about.
Do you have anything else to say about hospice that I might have missed, Tracy? I think I did miss some stuff about caregivers and.
So at Jessica's house, and Erin and I have been working hard with being able to figure out just to be able to get this information out. We had one education session where we did have a financial advisor, a funeral attendant, and then I spoke as well. So the hope is that we will continue having that in Huron County, and I think Erin and I working together to see where we'll be able to provide those. So the same thing with the advanced care planning books. We have them at Jessica's house as well. And my hope is with that as well is to have it out there that if anyone is wanting to get any of that information, just like I said, your biggest thing is just to call the hospices and ask the questions, and we'll be able to put you in the direction of where you can go, because we know that these are hard questions, and I think as time goes down to it's those hard questions, but feeling comfortable being able to talk about death. And that's, I think, as a group and panelists, that is our hope, that as we keep going, that people do feel more comfortable talking about it.
Anyone else?
Jay, I believe you have a question.
Yeah, I do have a question, and this was sort of briefly touched on just now and throughout the talk, but I would like to have all the panelists weigh in. And is it ever too early to start talking about hospice care?
No.
No, and just feel free to go with that, Laura. Is it ever too early? I'd like to hear.
No, the earlier the better, right? That means that you're planning, you're thinking. It doesn't mean that I think a lot of people, like Erin said, it is almost like you've given up. Not by any means. What you're more or less doing is taking that decision off your family. You're letting them know so that they're not having to make those decisions sort of at the last minute when stress is quite high. So the earlier the better. And then our care coordinators too, if you're involved with home and community care, they have the advanced care planning. They'll review those types of things with you as well.
There's another question that has come in. Would someone who is approaching end of life with dementia be eligible to go into hospice? Unknown trajectory, so they don't know what their life expectancy is, but.
So in Tracy, do you wanna take this, or would you like me to?
You go ahead. I think our answer is the same. So
Yeah, I think so too. So in each one of the reasons that the PPS is not the marker we use to designate eligibility for hospice is that the PPS was really designed and tested for folks with cancer, with cancer, with METs specifically. And so for some of the other illnesses, we look at some like different prognostic markers. So some of the prognostic markers that we're looking for in dementia are someone who is really not getting up anymore, who might not be eating anymore. Certainly age and frailty plays a factor. Recent weight loss of greater than 10 or 11% plays a factor. If someone has pneumonia and the goals of care no longer involve treating with antibiotics, that would be something we would take into account. If someone has higher stage pressure ulcers, particularly if they have multiple pressure ulcers, those would be factors we would take into account. Upper respiratory infections, all of these will be combinations. I think recent loss of a spouse is a prognostic marker as well. So it really is person-centered. We really look at the whole person and their individual situation.
It looks like that is all of our questions. Did anyone else want to tackle?
I'm so sorry. I was using jargon. So the PPS is the Palliative Performance Scale, and it's a scale that is used by healthcare providers to communicate about someone's level of functioning at a particular point in time. And it was designed to communicate about level of functioning as someone declines towards the end of their life and to death in folks with cancer, and has since been, extrapolated widely in palliative care, and is one of the tools that we use when we're talking about prognosis and when we're communicating between healthcare providers about someone's functioning.
I just have, I guess, one final comment, and I think I'm hoping that all the panelists would agree with me, is that being able to be a part of a person's life at their end of life for all of us is such a privilege. And I think that as people that are caring for their loved ones, how important it is for them to be able to realize that for us to be able to be a part of that is such a special thing. And being able to help them to be able to go through this process is also something that we really wholeheartedly enjoy doing. And however weird that sounds, it is how palliative care and end-of-life care kind of becomes something that is important to us, and to be able to care for your loved ones just as much as for you to do it as well, and for us to support you through that process.
Excellent. Thank you, Tracy. Okay, it looks like that's the end of our questions, and we're about 2 minutes to 1 o'clock, I believe. So I'm going to give some closing comments. As we conclude this lecture, we hope that it has proved to be educational and insightful to rural transitional care interventions from hospital to home. A huge thank you to our lecturers, Erin Donald and Meagan Nolan, and to our panelists, Laura Hawkins, Tracy Snell, and Lorna Coombs. We would also like to thank our sponsors for their continued support. Without them, this lecture series would not be possible. They include MicroAge Basics in Goderich, McGee Motors in Goderich, Libro Credit Union, Lighthouse Management in Goderich, McEwen and Fagan Insurance Brokers in Goderich, Huron Telecommunications Cooperative Limited, Huron-Tel, Zayers Goderich, CIBC Wealth Management, and the Goderich Royal Canadian Legion 109. Gateway is a not-for-profit organization with charitable status. We greatly appreciate and welcome any support we receive. If you would like to donate to Gateway to continue the support for this lecture series and our other health projects, I encourage you to visit the Gateway website at www.gatewayruralhealth.com/donate. If you would like to support our ongoing activities in other means, we have a fabulous online store. It features things like hats and toques and t-shirts and gardening equipment. Our next lecture series will take place on Tuesday, May the 7th, 2024, from 12 until 1 ET via ZO. Not quite sure what that is, Jay. Are you there?
Hi, I'm here. Yes. Actually, I have not looked ahead to see what our next lecture is either. So,
So it's a secret.
It'll be a secret.
Okay.
Well, we'll have it posted on our website shortly after this.
Fabulous. I just want to say thank you again to all the panelists. It was a wonderful hour spent, and I've learned a lot. So, thank you.